Inside the Royal Blackburn Hospital, the BBC was given unrestricted access to witness the pressures facing the NHS.
There'll be patients here for 6 and 8 hours. Can't find a bed for them.
Queuing for 5 hours in the corridor. It's not what you expect for a country like ours, is it really?
We need to get some blood from you.
What's it like here when it's busy?
Dangerous.
Yeah, it's frightening.
Are you able to run a blood gas?
Sunday night, a peak time in this A&E. 95 patients and just 33 cubicles and rooms. The sickest are seen first.
We actually have corridor nurses now as well, which shows times are very desperate.
The priority is to keep people safe. Across the week, we saw patients treated on corridors and side rooms.
I feel as though I'm going to collapse if I don't get laid down.
You need a bed.
Definitely.
It's distressing. It's really distressing for people.
How long have you been waiting for?
7 hours. We need beds and staff. It's just like banging your head against a brick wall.
You're in hospital, you need some privacy.
I mean, I am covered up, but it's not nice.
At its busiest, this was the paediatric emergency department.
These nurses and doctors are working really hard, but there just isn't enough of them. There's people lined up in corridors on beds. There's people stood appalling here, there ain't even enough seats to sit down. It's absolutely appalling.
The amount of babies that are sat on corridors is absolutely ridiculous. Absolutely ridiculous.
It's heartbreaking.
Is there anywhere for you to sit down?
No, the waiting room's full. They've put me here. We'll be stood here for 40 minutes.
How do you feel about all of this?
Frustrated, worried. Is it going to take something drastic for them to act quicker?
We used to come, we used to wait a bit in A&E, at least you'd have a seat. Now we're sat in a floor. Yeah, it's worrying.
As a doctor, how do you feel when you see babies like that?
It's unfair. It's unfair, and it's putting us in under big pressure.
By Monday morning, on average, patients were spending half a day in the emergency department.
Just let the staff get on with what they're doing.
Those delays are difficult to take for consultants like Helen.
I left here at 11 o'clock one night, having referred him into the hospital earlier, so about 9, 10 o'clock. And I arrived back at 11 o'clock the next morning and he was still here.
12 hours in A&E?
Yeah, more than.
What did that do to you when you came back in and you saw your patient?
It was upsetting. It was upsetting. Because you know it's not the care that you would want your own family to receive.
I'm going to go see what I can do to shift beds and create space.
Even paramedics queue. During our time here, the A&E only hit its 4-hour waiting target on one day.
When you get 12 ambulances in an hour, you know, you're going to have queues like this, and as a team, we work exceptionally hard. Like, it's not that anything's going wrong, it's the sheer volume of people that come.
ED sister, can I help? My name's Eve Gillespie. I'm one of the senior sisters in the A&E department at the Queen Elizabeth Hospital.
Lovely, thank you. So you've still got 2 empty at the moment? Lovely. Yeah. As soon as we get some space out here, we'll think about shuffling people around, okay?
The way that things have become in A&E over the last 2 years, you know, we're at breaking point. It can't carry on. The queues on the corridor and the situation that the patients are in and the department's in, it's unsafe.
I slipped down the stairs and I think I broke my foot. I'm in a lot of pain. Very bad.
So you just don't expect to see so many people and, you know, people not having beds, not being seen to by doctors. It just feels like we're in a third world country, to be honest with you.
We're probably seeing about 100 patients more per day than we were a year ago.
2 or 3 patients used to be stressful, but over the last couple of years, this is just an average day that we would have this many patients on the corridor at one time.
NHS is breaking at the seams. The amount of people who need the services that we can offer is growing, and we just do not have the resource to deal with them. Going into the emergency department to see a gentleman who's already been in the emergency department for over 8 hours. He needs to be in a bed on our medical admissions unit. We haven't been able to find that space for him. The reason we have people queuing around the corners in the emergency department is because the whole system is stuck. We're congested. There's nowhere for anybody to go. If I can't discharge people from the back end of the hospital, so people needing the long-term care because of lack of community services, that means there's no beds coming up on the acute wards, which means there's no beds coming up on the medical admissions unit, and that's why people are stuck in A&E cubicles or even on the corridor in the emergency department.
10 years ago, I never once nursed a patient in the corridor, never once had to shuffle people around and explain why we were sitting them out into the waiting room. It was easily managed within a department over the years. I mean, especially the last 2 years.
Renal colic man can go into 6.
It's just dreadful. There's just no space for people. I mean,
Walk round and see if there's anyone that can move out of cubicles so we can offload the new ones on.
It just seems to be acceptable to treat people on the corridor, and you know, it's not dignified, really, is it? It's not the way we want to treat our patients, but we don't have a choice.
I would often be brought to tears during my shifts because there was just so much pressure on me. When I graduated, I was so excited. I really wanted to do a job where I could make a difference and help people. But I've found, as time has gone by on the wards, things have just gotten more and more stressful, and we've been under more and more pressure. I felt like I wasn't giving good care to my patients, or the care that they deserved, rather, because there just wasn't enough time, and because I was so stressed and run down, I wasn't being as caring as I know I could be.
This is a subject that is close to all of our hearts. Do you ever worry who will look after you if you get ill when you're older? Do you worry your loved ones won't get the care that they need and also the care that they deserve if they get ill and are cared for by the NHS? Now, over the weekend, it was revealed a staggering 2 patients are dying from thirst or starvation every day in hospital. So do we trust the NHS to care for those that we love? And
I remember when my sister had her baby, and she was only going to be in for a day, and then she had to be in long because he got jaundice. And on the second meal that she had this sausage and mash, and the sausage was rotten. Properly rotten, and she's just had a baby. And so the family took in breakfast, lunch and dinner every day for the whole time that she was in there. But, you know, every day I was thinking, what about all the people here that can't do that?
Yeah.
And, I mean, there was an investigation last November, and hospitals were found to be serving out-of-date food from kitchens full of flies.
Oh.
Meals were being prepared in mouldy kitchens, putting vulnerable patients at high risk of food poisoning. I mean,
My sister is a nurse, and she works on the paediatric ward. She goes into oncology wards where they've got jelly and crisps and, you know, and things that sugar that feeds cancer and things like that. And you know, and you just think, what on earth is going on when we're giving our patients, any patients, the wrong nutritional food, something that could substantially help their treatment and make a huge difference in their recovery and even cure what disease they've got. We're not even getting to the root of that.
Well, I think what's so sad is we're talking about it now. I can remember 20-odd years ago talking to a friend of mine who was a dietitian in an NHS hospital, and she was sobbing with frustration over the fact that all she wants to do is heal people through food, and that's what she's trained to do, and she can't do it just because, for whatever reason, whether it's budgetary or management or whatever reasons. That was 20-odd years ago, and nothing's changed.
Everything about healthcare is complicated, including the politics. It's administered by provincial governments, but Ottawa sets the guidelines. Among the guarantees of the Canada Health Act, universal access for Canadians. But that doesn't extend to prescription drugs. This is the only industrialized country with universal health insurance that doesn't offer drug coverage. And 1 in 10 Canadians can't afford to pay for their medications. Getting health care can be a challenge for many of us, from long waits at the emergency room to simply trying to find a family doctor. And even if you have one, only about 40% of Canadians say they're able to see their doctors within a couple days of calling. Compare that to Germany, New Zealand, and Switzerland, where the number is about 70%. And yet the total cost of healthcare continues to rise. Estimated at more than $200 billion last year, that's about 11% of our gross domestic product, driven in part by new treatments and aging populations. Our lifestyles are adding to those costs too. A newly released study in the Canadian Journal of Public Health suggests the annual additional healthcare cost for every smoker is about $3,000. For those who are overweight, just under $1,500, and about $700 for those who are not physically active. An Ipsos Reid survey last June shows we consider the healthcare system the top issue of national concern, more than unemployment, more than taxes, more than political corruption.
So we know, as we just heard, that Canada is the only country that doesn't include prescription drugs in its universal health system. We all see patients every day who cannot afford to take their medicines, who are splitting pills or skipping doses or not filling their prescriptions. And yet at the same time, we pay among the highest costs in the industrialized world for our prescription medicines because we don't have any coherent system for dealing with pharmaceuticals. So
And the problem is that widespread. You're actually, in your practice, you see people
absolutely
every day?
We see it every day. And in fact, you know, you heard the 1 in 10 number, but in fact, the most recent survey suggests it's 1 in 5. And in some provinces, 1 in 4 Canadians who are not taking their prescription medicines as prescribed specifically because of concerns about costs. So if you think about the incremental cost of the healthcare system, when people's blood pressure isn't well managed, their diabetes isn't well managed, their HIV infection, their cancer drugs that they can't afford to pay for, we're paying for all of those complications when they land in the emergency department or in the inpatient wards at much higher prices.
Every day I see someone in the hospital who's admitted because they had a decompensation of their heart disease because they weren't able to take their meds.
Part of the challenge is that a lot of the $200 billion we're spending on healthcare is related to an aging population. So right now, 15% of Canadians are 65 and older. The number of older Canadians is going to double in the next 20 years, and they account for half of our healthcare spending. And the challenge is when we founded Medicare across our country, the average age of a Canadian was 27. We didn't live beyond our 60s on average. And our doctors, nurses, and social workers today in school are not mandated to learn about the care of older adults. So we have a perfect storm, and this is why the Canadian Medical Association, the Nursing Association, all the major associations, including the Canadian Labour Congress, all these groups have got together to demand that we start creating a national senior strategy that focuses on issues like pharmacare, but also issues of, making sure that older people don't age in poverty, making sure that we have the right health and social services available, because not only is that just better to meet the needs of an aging population, but it'll actually make our healthcare system sustainable. Problem is that right now we're very inconsistent in the way we provide care. And when you actually look at our Canada Health Act, when we created it when we were on average 27 years of age, we thought that all people needed were physician services and hospitals. We never thought about medications. We never thought about home care or long-term care. And that's actually what a lot of Canadians need now, especially as we age. So the problem is that we never actually thought about those things. We're literally being caught with our pants down. And if we don't actually get our act together, we're going to be in trouble.
Canadians love the ER. In fact, we make 16 million visits a year. But we wait, when we do, on average, about 4 hours to see a doctor. 10% wait 8 hours or longer. It's even worse for seniors. Among those 65 and older who require admission, 1 in 10 wait more than 28 hours to get a bed. Why all the waiting? The lack of fast access to family doctors is a factor. But a chronic shortage of ER doctors is the main reason. In some parts of the country, hospitals are so understaffed, they have to close their emergency rooms at certain hours. All these bad stats lead to one last one. Canada is ranked last out of 11 leading developed nations for emergency department care. So, how do we fix our ER problems? Time for some answers.
Why are we, as Canadians, such high users of ERs?
Well, Canadians are getting older. There's more immigration to the big cities, urbanization, as well as resource requirements. As those people are getting older, they're requiring more health care needs. So access to primary care is certainly an issue, But there's also the question of how we get patients to where they need to be after the hospital. That's also an issue that we should talk about. And all of that creates a bottleneck at the hospital. And the front doors, the marketplace, is the emergency room. And so what the public perception is that the emergency room wait times is a reflection of all of those stresses on the system.
We know that although, for example, the vast majority of Canadians have a family doctor or primary care provider, probably about half of us can't access that person on the same day when we call because we're sick and we need to be seen today. Similarly, as a family doctor, if I see a patient in my office who has a condition that is more acute than I can deal with in a 15-minute visit in my office, pretty much the only option that I have had, at least in the past, has been to send my patient to the emergency room. So we haven't created enough other entry points to the healthcare system. And so with the result that actually, as Jay says, it's not just the front door to the hospital, it's pretty much the only door to the hospital. And therefore, both family doctors and primary care providers and patients tend to use it. Okay. Almost every Canadian now has a family doctor. What we do have a problem with in primary care is getting same-day access to one's family doctor or primary care provider when we need it. And that can contribute to problems in the emergency department. But the other thing that often happens, as I mentioned earlier, is when you see a patient in primary care who's more complex or needs an urgent referral to a specialist or needs urgent imaging, or needs a CT scan, today or tomorrow, it's actually virtually impossible in most communities in Canada to get access to those things through any means other than sending the person to the emergency department. And so, ironically, we actually see a lot of people ending up in the emergency department at the recommendation of their primary care provider. And
it's very easy for a politician to stand up before voters and say healthcare is a right, and then passionately advocate for single payer or free healthcare or Medicare for all, whatever term they might use. But before we consider the merits of the government managing your healthcare, and that's what this all boils down to, maybe we should ask a more basic question. What do we mean by healthcare? Because if you get sick, and here we're talking major illness or you're in serious pain, you don't just want healthcare, you want quality healthcare. And where is your best chance of finding that? The answer is right here in America. For skilled doctors, cutting-edge medical treatments, and care without long delays, no other country rivals the United States. Not even close. Nobody from Texas is going to Canada for medical treatment. It's almost always the other way around. So let's imagine we make the change. We hear a lot about how great free healthcare would be, but it's only fair we look at the downside. The first is that government-run healthcare takes medical decisions away from patients, that means you, and puts them in the hands of bureaucrats. They decide, for example, how many MRI machines are going to be available, or under what conditions you can get back surgery or a bypass, or even whether you qualify for cancer treatment. That's how it works in the United Kingdom under its single-payer system. Because it has finite resources, the National Health Service, or NHS, sharply restricts access to treatments like hip and knee replacements, cataract surgery, and even prescription drugs to deal with common conditions like arthritis and diabetes. In a January 2018 article in the New York Times, patients in emergency rooms around London are described as having to wait 12 hours before they are tended to. Corridors are jammed with beds carrying the frail and elderly. To deal with the situation, hospitals were ordered to postpone non-urgent surgeries until the end of the month. That hardly seems like an improvement over what we have in the U.S. A second big problem with single-payer systems is that they are expensive. Really expensive. A recent study by the Mercatus Center at George Mason University found that a Bernie Sanders-style Medicare for All health system would cost a tidy $32.6 trillion over 10 years. That's on top of what the federal government spends on healthcare today. And this is not a new number. Other studies have found the cost to be roughly in the same range. So, how would we pay for it? Kenneth Thorpe, a professor at Emory University and health policy official in the Clinton administration, spells it out. If you are going to go in this direction, Medicare for all, the tax increases are going to be enormous. Not just for the rich, Thorpe estimates, but for working Americans and the poor too. Charles Blauhaus, the author of the Mercatus study, puts it this way. Even a doubling of all projected individual and corporate income taxes would be insufficient to finance these added federal costs. And he considers that a conservative estimate. Canada knows all about exploding healthcare costs. In Ontario, the country's biggest province, those costs took up 46% of its entire budget in 2010. By 2030, That number is projected to be 80%. In other words, in a few years, Ontario will have little money to pay for anything except health care. Finally, and perhaps most importantly, government-run systems depress the search for new cures. Biomedical research spending in the U.S. far outpaces that of any country with nationalized health care, even when you account for differences in population or size of economies. That's one reason medical breakthroughs rarely come from countries where the government controls health care. They come from the United States, where the government doesn't. The lion's share of biomedical research and development spending in the U.S., over $70 billion in 2012, comes from the private sector. Discovering new medical cures and technology is a profitable business, and thank goodness it is. Those profits drive innovation. Take away the profits, and you will surely take away the innovation. Single payer, free health care, Medicare for all, they might sound great, but like all visions of utopia, they ultimately produce a lot more harm than good.